Okay, great. Well, thank you everyone for attending this session. It looks like it's 4 o'clock, so we'll just dive into this here. My name is Aurora Quay, and I'm an anesthesiologist at Maine Health Maine Medical Center, and I focus on regional anesthesia and pain medicine, along with improving opioid use disorder treatment and care perioperatively, as well as for ICU patients. And today our panel discussion is entitled Goldilocks in the ICU and Striking the Right Balance for Managing Pain, Sedation, and Providing Comprehensive Opioid Use Disorder Care. So for the sake of time, since we have a lot to cover, let's dive in. So I'm going to start a discussion where I talk about pain management and that comprehensive care for patients with opioid use disorder that present to our ICUs. So the questions that I will answer are: one, how do we care for these patients? Two, what is the role of buprenorphine and methadone in the ICU? And then lastly, can the ICU serve as a bridge for offering opioid use disorder treatment? And then we'll transition to Dr. Ray Lane, an intensivist and palliative care specialist at Beth Israel Deaconess Medical Center. And she'll talk about analogous sedation and non-sedation in the ventilated patient and really trying to strike that right balance. So the questions that she'll answer are: what are our current guidelines for analogous sedation? She will also crowdsource to identify what your current practices are at your institution. So there will be a Q&A polling in this session. So if you want to actually open this up on your own app and just get ready for that, that would be great. Just for all of you that don't remember, this session is PN306. So you can just type that in the search bar, and we'll remind you again. And then the last thing we'll talk about is: how do we provide care for our palliative care patients that present to the ICU? And lastly, Dr. Olive Victor-Starter, also an intensivist from Yale New Haven Hospital, she'll round out our discussion to review acquired opioid use disorder that occurs for our patients that come to the ICU, as well as the incidence of chronic pain in these patients. The questions that she'll answer are: how common is persistent opioid use after ICU care? Which patients are most vulnerable to persistent use? And then she'll review opioid stewardship opportunities we can all consider. Okay, great. So we're just going to dive in. So we are all aware of this slide here. We've been dealing with this epidemic for almost 3 decades now with minimal signs of abatement. And it really has gotten worse because of the synthetic opioid compounds that have contaminated our drug street supplies. And so right now it's estimated that 48.5 million adults actually have a substance use disorder. What does that mean for our intensive care units? Well, up to 1 in 4 patients actually comes into the ICU with a substance use disorder complication. And this could be alcohol use disorder, cannabis use disorder, and of course opioid use disorder. And then of those patients that have opioid use disorder, in the past 5 years, there's been a 34% increase in opioid-induced ICU admissions. Why is this important? Well, because these patients have worsened outcomes. Length of stay is higher, readmission rates are higher, hospital costs and mortality also are higher. And managing these patients is uniquely complex because they can have several competing conditions that compound and overlap on one another. And a very common first entry point into the ICU actually is, of course, acute overdose, where patients come in respiratory failure, cardiac arrest. And then on the other extreme, you can have acute withdrawal that a lot of times, if it isn't on our radars, it can go unrecognized. And if we don't treat it, you can exacerbate hemodynamic instability. And then you also have the complications with opioid use disorder, like sepsis that occurs with IV drug use, endocarditis, the trauma that can occur due to high-risk behavior, and then, of course, pain management is very challenging in this group. And underlying all of this, you have patients that have opioid use disorder, and they're coming to the ICU for something not related to that. So ultimately, we need to recognize that critical illness can present a unique opportunity to be able to engage patients with opioid use disorder treatment. Unfortunately, there's not great guidance that exists for us right now, specifically in the ICU. There's great guidelines for perioperative medicine, also for hospital medicine. But in the ICU, this was a study that came out of Beth Israel Deaconess Medical Center, where they surveyed ICUs across the country. And while the majority of them did have guidance for pain, sedation, delirium for opioid-naive patients, only 7% of institutions actually had guidance for patients with opioid use disorder. Only 1 had guidance for how to manage buprenorphine and methadone. And of course, this has significant implications, and one of those is rising healthcare costs. So this was a study that came out of Denver Health, which is a hub and spoke safety network institution in Colorado. And what they did was they looked at their hospitals and they identified patients that had opioid use disorder that were eligible for treatment. And here, about half of them actually did end up receiving treatment. But of those ones that weren't linked to services in anticipation for discharge, they had the highest healthcare costs, actually, $2,300 a month when you looked at the ED visits, the hospital services, and medication visits. So much more than those that were linked to care. So it really shows a lot of this also has to happen at the system level in terms of figuring out a way to start the medications, make sure that they're continued on them after they leave our hospitals. And when we actually look at how they're being used in our ICUs, there's a lot of work to be done. So this is a study that was published in Critical Care Medicine last year, where they looked at over 600 hospitals across the country. This is claims-based data. And they found that only 19% of those hospitals actually, of those patients that went to the hospitals, only 19% of them received buprenorphine or methadone. The other interesting finding that they identified was that for those patients that got medications for opioid use disorder, their chance of receiving a full opioid agonist was much lower. And we've actually shown consistent findings at our own institution. So these are two articles that I published with my ICU group, where we looked at patients with opioid use disorder that came to the hospital on buprenorphine. And we just asked a simple question, are they getting it while they're in the ICU or on the general ward? And what we found was that there was a 6-fold increase in opioid utilization when they did not get their buprenorphine. It was a 9-fold increase on the general ward. And then the next question we asked is, what do we do for these patients at discharge? And for those patients that did not go home with a buprenorphine script, 70% of them were getting a full agonist prescription, drugs that they potentially abused in the past. We followed them for up to a year, and at that time point, there were still almost a quarter of patients that were receiving that prescription. So it really shows that we should be continuing it, and not continuing it is harmful. So what about buprenorphine efficacy in the ICU? So this is a paper that came out of Australia, and in this group, they actually observed patients that weren't opioid dependent. They were patients that came in for critical illness, and they were on continuous IV opioid infusions, and they wanted to wean them off of them. They used either buprenorphine or oxycodone. And what they found was that pain scores were the same, very similar in both groups, and that opioid utilization was also the same in the buprenorphine group versus the oxycodone group. So it means that buprenorphine use is feasible in this setting. And so the next thing that they did was a subgroup analysis where they looked at mechanically ventilated patients and then opioid utilization. And what they found was that for vented patients, they use more opioids, which is not surprising. But the buprenorphine group had similar utilization as the oxycodone group when you're looking at morphine milligram equivalents. Another study that actually looked specifically at opioid-dependent patients that they actually wanted to transition onto buprenorphine. This was a descriptive study just to show feasibility. Of those 153 patients that met criteria, they all were safely transitioned to buprenorphine. And again, their opioid utilization decreased significantly. It was over a gram a day to 260 milligrams in morphine milligram equivalents. So again, it shows that we should be continuing these medications. We should start them when they're not contraindicated. Further evidence exists in that study that I talked about before with those 600 ICUs of all ICU types, and when their subgroup analysis where they just looked at mechanically ventilated patients, a third of them were receiving buprenorphine. So we can give this medication to patients that are vented. So why is buprenorphine use so challenging? Why aren't we doing it more? A lot of it has to do with its pharmacology. So this is an important table, and it shows the equilibrium dissociation constant for a lot of the medications that we use commonly. The take home here is the lower the Ki, the higher the binding affinity. Buprenorphine is the most potent. It binds the receptor for the longest amount of time, 8 minutes as opposed to milliseconds, and it binds quite strongly. So what that means is that it's not easily going to be displaced when it's given along with another full opioid agonist. So to take it one step further, if you have a patient that is on Dilaudid, for instance, at a pretty high dose, and you give them buprenorphine, you're going to displace that Dilaudid. You're going to get a precipitous drop in that opioid effect that's kind of similar to naloxone. So agitation or somnolence will turn to agitation, and analgesia can turn into significant pain really abruptly. And this precipitated withdrawal is reported to be worse than the withdrawal that patients typically experience traditionally in between opioid exposures for active drug users. So it's something that you really want to avoid at all costs. And so this is actually something that we do at Maine Medical Center, and we're using this in our ICUs. It's called a buprenorphine microinduction initiation protocol. And so what the strategy here is to slowly introduce buprenorphine over time, gradually, so you don't develop that precipitated withdrawal. So what you do is you continue the patient on that current opioid that they're on the entire time for the initiation process. And because we know that buprenorphine is so potent, you just add a little and it's going to slowly displace that full agonist that's occupied at the opioid receptor. At the end of that initiation process, buprenorphine is at a dose where it is saturating opioid receptors. You can safely stop that opioid that was at that dose, and you've limited that chance for precipitated withdrawal. And it's really an approach that providers should become increasingly familiar with, because with the elimination of the X waiver in 2023 now, anyone that has Schedule III prescribing authority through a DEA can prescribe buprenorphine. So this can be a touch point for getting more patients into treatment. And again, we're using it right now at Maine Health. It's a great method to prevent withdrawal. This is a QR code for the order sets that we're using for anyone that's interested in potentially trying this in their institutions. A lot of literature in the emergency department literature as well as hospital medicine literature. There's not much, though, in ICUs. This is one case series that was recently published where they did that same initiation process that I described over 7 days for patients, and all those patients that they administered the buprenorphine for, none of them developed precipitated withdrawal. The majority of them were able to be successfully extubated during the protocol. There was only one patient, but that patient didn't survive because of pre-existing conditions. But all the patients that did survive were discharged with buprenorphine. So it is feasible. It can be done. So now we're going to talk about methadone. There's not as much controversy with methadone because of the fact that it is a full-acting opioid mu agonist. And a lot of times when methadone's used, it's used to wean patients off of IV opioids. So the first 3 studies here are studies in patients that were mechanically ventilated for at least 3 days, and the outcome was to try to reduce and wean them off of those continuous infusions of either fentanyl or Dilaudid. And they used either methadone to do that or oxycodone. And for the first study, the methadone group was able to stop the IV opioids over 2 days quicker than the patients that were weaned with oxycodone. In the second study, they found that patients were able to get extubated on average 5 days sooner with methadone compared to the ones that were transitioned with oxycodone. And they were twice as likely to be able to be weaned completely off of opioids by day 5. The last study was in pediatric patients. Again, they were on IV fentanyl infusions. They wanted to get them off of it. All these patients did receive methadone at a 2.5 to 1 conversion ratio. And the majority of them were off of the infusion because of the methadone within 2 days. And they also had less withdrawal than historical controls. The last 2 studies here were specific for opioid use disorder patients. And so in this first study published in the Journal of Addiction Medicine, it was a descriptive analysis of the ability and feasibility of titrating methadone to reduce withdrawal. These patients had a higher dose of methadone that they were given. It was 40 to 65 milligrams as opposed to those other studies where it was about 20 milligrams. But in any event, it took about 4 days to be able to get patients on that maintenance dose of methadone. It was safe and effective, minimal adverse events. The last study was actually a randomized controlled trial where they used methadone specifically for opioid use withdrawal. There were other patients that were randomized to get IV fentanyl to deal with withdrawal symptoms, and the methadone group had quicker withdrawal significantly. So it is a great medication. We also can use it more frequently. But of course, there are risks associated with it that we need to consider, especially for critically ill patients. So we know that methadone prolongs the QT interval, and this risk increases at higher doses. And then also, in terms of respiratory depression, because of the variable pharmacokinetics that can occur with like hepatic failure, for instance, you can have increased toxicity with methadone in patients with those conditions. You have to be very careful with this drug, maybe not use it at all. It's also kind of interesting that methadone is responsible for 10% of prescription opioid deaths, even though it accounts for less than 2% of prescriptions. So because of that inter-individual variability in terms of metabolism, it can make it a very difficult drug to know exactly what concentrations are for patients. In terms of drug interactions, its metabolism can be interfered by other medications that are used in conjunction. So erythromycin and clindamycin, diltiazem medication we commonly use, those can also help to reduce methadone metabolism, which again increases toxicity. And then another thing to consider is when you're converting other opioids to methadone, it's a nonlinear conversion because of those inter-individual variability in metabolism as well as the redistribution that occurs at higher doses. And so what you need to do is give less bioequivalent methadone for these patients, okay? So if you have a patient that's on over 1,000 morphine milligram equivalents of opioid, you would use a 20-to-1 conversion ratio for methadone as opposed to the 3-to-1 that we traditionally use for patients that are on lower equivalents. Last thing to consider is that patients should not get more than 40 milligrams of methadone a day because doses greater than that cannot be prescribed unless the patient gets it from a treatment facility. So the recommendations are these patients should get an EKG before therapy. You really want to monitor for sedation changes. You want to avoid it in patients that have severe hepatic disease as well. Okay, so now we're going to transition into opioid withdrawal in the ICU, and it can be quite challenging to identify since it does mimic other conditions. In terms of the signs and symptoms, you want to look out for hypertension, tachycardia, increased need for suctioning, or patient that has ventilator asynchrony or rising sedation requirements without any other cause. It really should be on our radars. And it's hard to identify sometimes. For our conscious patients, it's pretty easy because they can self-report by using the clinical opioid withdrawal scale. But for our intubated and unconscious patients, there's no clinically validated tool that currently exists. So you can use the withdrawal assessment tool. This has been validated for pediatric patients, because it doesn't require verbal input. It looks at objective assessments such as yawning, diarrhea, tremor, these types of things. So it's something we can consider if it's on our radar. And then also the Richmond Agitation Sedation Scale, is routinely performed by nursing teams to identify if a patient either combative or unarousable. So if a patient is showing trends that are leaning towards being combative, it's something then to consider. But the big thing is it just needs to be in our radar. And once withdrawal is identified, we really should target those specific symptom clusters. So for the autonomic symptoms, give Precedex. For the GI symptoms, Zofran, Imodium should be considered. And we've also talked about the importance of methadone and buprenorphine. So the last thing that I'm going to talk about is acute pain management and our goals of care. It's important to recognize it early because undertreatment of pain is associated with self-directed discharge. And then also we want to make sure that we are engaging patients in their care, telling them that we understand that their pain is valid and that we're working on it. It doesn't last always. Just having these discussions can be helpful. We want to maximize the use of adjunctive analgesics whenever feasible. Multimodal analgesia is great. Regional in the ICU, we do that a lot at our hospital when it's indicated. These patients are going to need to use opioids, and you have to be okay with giving them higher doses. It's good to transition them off of IV opioids as soon as possible. And of course, we want to avoid giving them drugs that they've abused in the past if that's possible. And then for withdrawal prevention, we've discussed the importance of methadone and buprenorphine. So this is a QR code for a paper that we recently published that kind of summarizes all of this in terms of how to manage the critically ill patient with opioid use disorder. And now we'll transition to Dr. Ray Lane. Thanks.
Good afternoon. Aurora did mention at the beginning that I do have an audience response. And so if you bring up on the app and search for PN306, that'll bring you to the point where you'll get the question. My name is Ray Elaine. I am an anesthesiologist and an intensivist at Beth Israel Deaconess Medical Center in Boston. And relevant to this talk is that I recently completed a fellowship in palliative care, and that training will in part inform what I present to you today. I have no disclosures. So we're going to talk a little bit about guidelines, US guidelines specifically. And in 2013, the Society of Critical Care Medicine published pain, agitation, and delirium guidelines. In 2018, those guidelines were updated. 2 more domains were added to include immobility and sleep disturbances, hence the acronym PADIS. The PADIS guidelines are a comprehensive document. They include an in-depth review of the literature, and they have many, many great references. They make over 30 recommendations using the GRADE principles. And the writing of the guidelines included 32 experts, but importantly, on their panel were also 4 critical care survivors. The guidelines emphasize treatment of pain before initiating sedation therapy and using a multimodal approach. This analgesia first approach is supported by the recognition that even sedated patients can feel pain and that untreated pain can cause poor outcomes. For example, perpetuating delirium, and then longer-term effects such as sympathetic nervous system stimulation and deleterious immunomodulatory effects, particularly for cancer patients. My colleague, Dr. Victor's daughter, will discuss in detail that pain is a common symptom in ICU survivors and those who suffer from PICS, post-intensive care syndrome. So analgesia first makes sense, and the 2018 guidelines emphasize this multimodal approach with acetaminophen, ketamine to be considered as an adjunct in post-surgical patients, treating neuropathic pain when it's present, and importantly, utilizing assessments and protocols to guide your pain management in the ICU. Multimodal is important in striking the balance of treating pain, but also avoiding overuse of opioid analgesia, which is also harmful and the topic of our session, because it can potentially incite delirium, that is overtreatment with opioids. It also certainly can prolong mechanical ventilation duration, hospital and ICU length of stay, and recently studies have shown that actually increase mortality rates with overuse of opioids. With respect to sedation, we now have over 2 decades of accumulating research suggesting that lighter sedation is associated with improved outcomes, including lesser mechanical ventilation, shorter ICU and hospital lengths of stay, and in some cases, mortality. So these 2018 guidelines urge light sedation with daily wake-ups, and in cardiac surgery patients, propofol is preferred over benzodiazepines. Otherwise, either propofol or dexmedetomidine is suggested for mechanically ventilated patients. These guidelines were updated in 2025. Notably, no changes were made to the pain recommendations, and the panel suggested they had insufficient evidence to recommend benzodiazepines for anxiety. What they did suggest that in situations where light sedation or reduced delirium rates was of the highest priority, that dexmedetomidine was preferred over propofol. Although these guidelines are a valuable resource, they provide no special guidance about treatment of the critically ill patient with opioid use disorder, as Dr. Quay mentioned. So, if lighter sedation is better, what about taking this to the far extreme of non-sedation? And this study, termed non-SEDA, delved into this, building upon a pilot study from the same authors, which showed diminished days on the ventilator, diminished ICU and hospital length of stay with no sedation as compared to light sedation. It was conducted in 8 medical centers in Scandinavia, predominantly Denmark. My question when I first read this study was, could we actually mimic this in the United States? And culturally, I think that our patients have different expectations about pain and discomfort associated with medical care. And this may be quite different than other areas of the world. Also, in my ICU, I would likely have a hard time getting buy-in from the critical care nurses with whom I work. This would be akin to asking them to walk a tightrope of trying to keep the patient awake, but not having a self-extubation. The authors of this study do acknowledge that it might have been difficult or impossible to perform this study without the 1-to-1 nursing ratio that they enjoyed. Anyway, getting into the study, the sedation group received propofol infusion for 48 hours and then followed by midazolam. The non-sedation group could receive boluses of morphine as needed. Dexmedetomidine was actively discouraged in both groups. There was a significant crossover. 27% of patients in the non-sedation arm could not be adequately and safely cared for, and thus they crossed over. The most common reason was agitation, followed by hypoxia. Also, the no sedation group received higher doses of morphine over the first 3 days. The meaningful findings from this was that despite the author's hypothesis, there was no difference in mortality at 90 days in those who were not sedated. Secondary outcomes revealed a trend toward more thromboembolic events in the sedated group. This study, non-SEDA, generated a series of sub-studies seeking to look at other important outcomes of no sedation. These were largely negative, showing no difference in cognitive function at 3 months post-ICU. Reassuringly, no increased PTSD or anxiety or depression 3 months post-ICU, no difference in physical function or ability to perform ADLs. The only positive finding of non-sedation was improved physical recovery at ICU discharge, although this didn't seem to be sustained at the 3-month mark. Next, I want to ask you all in the room right now to ask, how do you provide analgesic sedation for your typical patient? So if you pull it up on the app, just type in your answer, including whether you use your agents in infusion or bolus form. And I know it can be hard maybe to generalize. I think all of us individualize our care to the patient, but if you just answer for your typical patient. So we're getting a word cloud here. And I'm seeing a lot of dexmedetomidine, continuous dexmedetomidine. A fair number of opioids are mentioned up there, and it looks like infusions. And propofol. That's helpful. Let's turn to the literature next to try to get a view of what is the current practice of analgesic sedation in mechanically ventilated patients. This study from New York Presbyterian, Columbia University, gives us some indirect data of analgesic sedation from a study that was comparing sedation practices in mechanically ventilated patients in the ICU by 2 different teams. Importantly, 96% of these patients received continuous sedation on the day of intubation, with more than 80% receiving opioid infusions, and half or more receiving benzodiazepine infusions. Here's more indirect data about sedation practices from a recent study from Boston. This study looked at a propofol sedation protocol for mechanically ventilated adults. It occurred in my home institution, although I was not involved in this study. And the table in the lower right here depicts protocol violations. That is, what infusions were added before the prescribed propofol dose was reached. And most commonly, 63%, an opioid infusion was added. This was followed by dexmedetomidine in 35% of patients and benzodiazepine infusions at 12%. So the point is that despite guidelines advocating opioid minimizing, real-world practice still relies significantly on opioid infusions as part of an analgesic sedation regimen. Now we're going to turn to a topic near and dear to my palliative care heart. That is, what happens to our analgesic sedation plan when the goals of care change? And this is important because 20 to 30% of U.S. deaths occur in the United States in the ICU. We actually have recent data showing that the percent of deaths occurring in acute care hospitals is falling. And that is good because when you ask, most patients do not want to die in a hospital. However, the data are showing that there is an increasing use of ICU care in the last 30 days of life amongst Medicare beneficiaries. So that's a lot of patients. And what it tells me is that the transition to end of life is happening in the ICU, with a majority of ICU deaths now planned and following a decision to pursue withdrawal or withholding of measures and shifting to a more comfort-focused care plan. We know that half of these decisions involve withdrawal of mechanical ventilation. Thus, this significant number of patients represents the intersection of critical care with palliative care. And as intensivists, we need to know how to perform extubation at end of life, allowing patients to die without suffering pain and dyspnea. And clearly, that care involves analgosedation to deliver the type of death that most patients and families request. And I would argue that opioids currently are our best tool to achieving that death. Literature on this topic shows that pain and dyspnea are highly prevalent at end of life. Assessment scales are underutilized. Our doses of analgesic sedatives are affected by ICU-induced opioid tolerance, or, as my colleague Dr. Quay has shown you, the rising proportion of ICU patients who come to us with prior opioid use disorder. And there's little evidence to guide how we treat these patients, with most recommendations being expert opinion. Looking a little deeper, research shows us that in critically ill patients, pain at rest is present in 50%. Pain with procedures in 80%, and the severity of that pain is rated moderate to severe. Dyspnea is also common. It occurs in 40% of critically ill patients and 50% of those who are mechanically ventilated. When you ask patients to characterize their pain, they describe it as air hunger, which is extremely anxiety-provoking, and as I'm sure many of us in this room are familiar with, leads to this vicious cycle of dyspnea and anxiety. So which ICU procedures are most painful? Well, survivors rate arterial line placement, chest tube or drain removals, and endotracheal suctioning as the most painful procedures, and they rate them with a median pain score of 5 on a numeric rating scale. Turning for a moment to the question of how do we assess pain in mechanically ventilated patients, it's difficult, but there are validated scoring systems as depicted here. For patients able to self-report, the numeric rating scale visual should be familiar to all of us. But for patients who cannot report, two of the more commonly used behavioral methods are the CPOT, Critical Care Pain Observation Tool, where the goal is a score less than 3, and similarly, the Behavioral Pain Scale, where the goal is less than 6. Both of these scales incorporate observations of facial expression, movements, and ventilatory compliance to objectively quantify pain. Unlike pain, dyspnea was not easy to quantitate in intubated patients until about 15 years ago, when the RDOS, Respiratory Distress Observation Scale, first popped into the literature. And this is particularly important because in ICU patients at high risk of dying, dyspnea is the reported most distressing symptom. What is the RDOS? Well, it incorporates 8 parameters that you see here on the slide, and these parameters were chosen based on videotapes of failed ventilator weans with patients experiencing dyspnea. It's been well validated now across disparate ICU populations, and the goal indicating no respiratory distress is less than 3. Assessment scales for pain and dyspnea are critical for our role in palliative extubations. There are two described routes for performing palliative extubation. The one on the right, the terminal extubation pathway, is what is most commonly practiced. It involves administering anticipatory medications, predominantly opioids, and then extubating. The benefits to this pathway are that it is a shorter process. However, we're acquiring evidence now that it does result in more dyspnea, gasps, and stridor. Most palliative experts now are advocating for this left-hand pathway termed a terminal wean, which involves a stepwise reduction in ventilatory support, stopping when there is evidence of respiratory distress and administering medications. The upside to this pathway is that there are demonstrated lower rates of respiratory distress after extubation. However, that can be accompanied by the fact that it may be a longer process, which any of us who have worked in the ICU can see can be excruciating for families who might be waiting in almost a death vigil at the bedside. Pertinent to this topic of how to manage symptoms associated with palliative extubation is this soon-to-be-published prospective observational study of 153 patients at 2 Boston medical centers who underwent palliative extubation when they transitioned to comfort care. The RDOS was used to assess respiratory distress from 1 hour pre to 3 hours post-extubation. And as you can see from the pie chart here, it came from a mixed group of ICUs. 90% of the patients experienced at least one incidence of respiratory distress within 3 hours after extubation, with a longer ICU stay being a risk factor. And I wonder, does this indicate that these patients had become tolerant to our analgesic sedatives, or did they represent patients who came to us with pre-existing opioid use disorder? The take-home message from this study is that patients treated with anticipatory opioids 1 hour prior to palliative extubation were 26% less likely to experience a distressful episode. And that was not true of patients who received anticipatory propofol or benzodiazepines. So, in summary, this study is providing evidence to support the expert guidelines which advocate for opioids when in the ICU we are providing end-of-life care. I'm now happy to turn over the podium to my colleague, Dr. Victor's daughter, to complete the presentation, and I'll look forward to your questions at the end.
All right, good afternoon or evening almost. I'm fully aware that my talk is probably the only thing that stands between you now and happy hour. So I'm gonna try to get through this in a timely fashion. My name is Ole Victorsdottir. I'm at Yale School of Medicine. I'm an anesthesiologist and an intensivist. I have no disclosures. My focus today is gonna be on acquired opioid use disorder after ICU opioid exposure. All right, as we've already heard from the previous talks from my colleagues here, analgesia first is a PADIS recommendation in the ICU. Opioids, however, are what is mostly used for ICU patients for analgesic sedation, as we've heard from Dr. Elaine. It is actually estimated that more than 80% of patients on mechanical ventilations receive opioids, increasing up to more than 90% in patients who remain ventilated for more than 7 days. So prolonged infusions are common. So there's a concern that ICU opioid exposure may contribute to iatrogenic opioid use disorder. Treating pain adequately in the ICU setting while attempting to decrease risk of persistent opioid use is a delicate balance. As we've already heard, we have to remember that undertreating pain can be harmful. Inadequate analgesia can worsen recovery and contribute to chronic pain syndromes after ICU, which in itself might drive long-term opioid use. Chronic pain in the ICU is common. It's been shown to affect up to 77% of ICU survivors a year after their stay. Now, this slide is very busy, but it shows results from a few different studies on frequency of opioid use after discharge in patients who received prolonged opioids in an ICU setting. It's not an extensive slide in any way, but it lists some of the more prominent studies on the topic in the last 5 to 6 years. And it shows the wide variety and timelines used when this is looked at, and the patient population. So if you look at the sirens there and you imagine that that's a timeline of sorts, and then you look up here, you see this is ICU survivors discharged from the hospital, 7 days out, 3 months out, et cetera, up to a year out or 2 years out. I also want to point your attention to these little colored persons here up in the right-hand corner, because I'm going to use these symbols throughout the presentation. I would say the most important one in this setting is the light blue one, or the opioid naive group. These are patients who come into the ICU without having used opioids. So they're opioid naive when they're admitted to the unit. The red one is a patient who has used opioids previously, is on chronic opioids when he comes in. And the navy one is the total cohort, the mixed cohort. So for those studies that look beyond the discharge, which is here, there seems to be a consistent theme. So most ICU survivors do not become long-term users, and now I'm referring to the opioid naive group, but a measurable minority does. So if we zoom into the light blue group here, you can see that the numbers are in a pretty small range, from 2.6% up to 5%. And the studies in pink here, they use a different methodology. So although the numbers at the end here are large, they summarized all opioid use in the first year and then in the second year after discharge. The final study at the bottom here looks specifically at traumatic brain injury patients, so from the neuro ICU, and these numbers are significantly higher, and we'll get to that a little bit later. So how does this compare to other acute care settings? If we look at the emergency department and patients who have a single visit to the ED, 1% of them had chronic use in the 1 year following that visit. For patients having what was defined as minor surgical procedures, 90 days later, 5% were using persistent opioids persistently. And for like a larger scale surgical procedures, 6% of opioid naive patients were still using opioids 90 to 180 days later. So not too far from these numbers. However, in some instances, it seems like these numbers might be downtrending. On this slide, you see actually pretty remarkable numbers from the VA system looking at downtrending frequency numbers of persistent opioid use for post-surgical ICU patients. They speculate that the increased awareness of risks of opioids in general contribute to this, the PADIS guidelines, and they started a specific opioid safety initiative that they think helped this positive trend. Now, does persistent opioid use after ICU discharge affect mortality? The answer seems to be yes. So there was a study done by von Ulrich and his colleagues in Sweden. They have a very large ICU registry of more than 200,000 patients, and they looked at all-cause mortality after ICU discharge. They were clearly adequately powered to look at these outcomes. They found that chronic opioid use after ICU translated into roughly a 70% increased risk of mortality compared to those who did not continue on opioids after discharge. And this risk was even higher for opioid naive patients. So we have more studies from Denmark and South Korea who looked at mortality, but they looked at chronic users that were admitted to the unit, and they had similar results. US data, we have 30-day mortality with odds ratio being 1.6 for opioid-naive patients, 30 days out of discharge. So the answer definitely seems to be yes. Factors that may play a part in this is that, well, we know that recognized adverse effects of opioids, such as delirium, constipation, respiratory depression, have all been reported to impact ICU mortality. Also, chronic opioid use might comprise risks of myocardial infarction, stroke, venous thromboembolism, and inappropriate immune modulation, all of which can add to the already poor prognosis of the ICU patient. So the next natural question is, which patients are at greatest risk for becoming, for having iatrogen opioid use disorders? Many factors have been studied, some showing strong associations, others have inconsistent results. But one of the strongest signals, which will not be surprising, is chronic use prior to ICU admission. So you come in on chronic opioids, chances are you are discharged on chronic opioids. This signal is consistent through multiple studies. This cohort of patients is usually a very small part of the total cohort. However, it's important to remember and recognize that a lot of patients are probably not reflected in this data, the patients that are non-prescription users, because most of these studies look at prescriptions filled prior to coming in. So you have a number of patients who are not going to be included in the data. This study here by Vampol and colleagues out of Maine, they compared persistent opioid use after discharge among patients with and without chronic use prior to coming into the unit. 3,000 patients, it was a mixed ICU cohort between MICU, surgical ICUs, and their primary outcome was persistent filling of opioid prescriptions that they documented in their prescription monitoring program 4 to 6 months after discharge. And the odds ratio for chronic users coming into the unit and 6 months later still being on opioids was 57. Yes. These patients only made up 8.6% of the cohort. However, they accounted for 61% of the patients with persistent opioid use after discharge. So how about patients who are sort of intermittently using opioids? So when these patients come into the unit, there was a study by Yaffe and his colleagues. They compared chronic users to intermittent users. They used the same definitions for those as the Vampol study. And they found that intermittent use did not seem to carry through the ICU hospitalization. So those did not seem to be affiliated with persistent use, but chronic use did. All right, the next logical risk factor to consider is opioid dose and duration. Does receiving a higher dose of opioid in the ICU increase the risk of persistent use? Yes, the evidence does suggest correlation, especially at higher cumulative doses and in opioid-naive patients. So this retrospective cohort study from last year looked at almost 7,000 patients, non-surgical, so MICU patients, across 21 hospitals in the Kaiser system. So over the first year, 43.6% filled an opioid prescription. And what they did, they categorized the patients by average daily IV opioid exposure during mechanical ventilation, and they divided them into 3 terciles, so low dose, medium dose, and high dose. They used, for their study, IV fentanyl equivalents, and for consistency for this talk, I'm going to convert them now quickly to morphine milliequivalents. So there's that. And if you look here, you will see that the patients in the medium and in the high terciles, so higher doses, these here, had a higher risk of filling opioids in their first year. They also had a higher likelihood of persistent use. So their findings suggest that exposure to opioid during mechanical ventilation, which importantly may be a modifiable factor, I'm looking at non-sedation over here, may influence patients' opioid use in the long term. All right, how about different ICU populations? So relationship between ICU opioids and persistent opioid use is not uniform, and outcomes seem to vary somewhat by ICU population and ICU indication. Now, there is a stronger signal and dose effect in the surgical and the trauma ICU population, where the frequency is about 4 to 5%. This is opioid-naive patients that I'm talking about. In the SICU, obviously, you have patients with surgical pain, especially cardiac surgery patients, major thoracic, major abdominal surgery patients. They receive larger doses, both intra-op, post-op, and as a surgical patient, you have a greater likelihood of being discharged with an opioid prescription. Trauma, and especially traumatic brain injury patients, are particularly high risk. These patients have, if you remember that last study from my first slide, they had much higher numbers. That was traumatic brain injury patients. These have severe acute pain syndromes, these patients. They often have long ICU stays, higher risk of neuropsychiatric sequelae like depression, post-traumatic stress disorder, which can also correlate with opioid use. Now in the MICU, the baseline persistent use rates are lower in the MICU patients, 2.6 to 4% or so. So not very much, but they're slightly lower than the SICU patients. The indication for these patients is usually somewhat different. It's usually mainly for sedation and vent synchronization. Patients with MICU problems, COPD exacerbation, pneumonia, ARDS, etc. I just put up here malignancy patients. There's not a whole lot of data specifically on, I'm thinking about these higher opioid use malignancy cancer patients that are on high doses. So they're sort of a group of their own, but they're important to keep them in mind. And then I put down their sepsis patients. Obviously, sepsis can happen in any ICU, but the sepsis diagnosis has been linked with increased opioid use after discharge. It's important to keep that in mind. Burn patients, same thing, not a lot of data on them, but it's an important subgroup that's important to keep in mind. They usually need extremely high opioid doses in the unit. And they also suffer from neuropathic and chronic pain. Now, opioid-free duration or opioid-free days have been shown to be another strong factor, a protective factor for opioid use post-discharge. And this seems to be the case both for patients who were chronic users coming in and the opioid-naive group. And this suggests that more aggressive opioid weaning with opioid-free periods prior to discharge may be a promising method. Similar data exists not only in the ICU population, but also in hospital patients in general. The concept of hospital opioid-free days came from Donahue and his colleagues, and they looked at almost 150,000 opioid-naive patients in a hospital setting, and they identified a lower risk of persistent use after discharge, A, if opioids were administered on a smaller percent of hospital days, and B, if the opioid-free duration prior to hospital discharge was longer or greater than 24 hours. So that's pretty important. The association of ICU length of stay sort of varies between studies. Many studies don't find any association. However, it's mainly where we're looking at longer stays in the unit, especially greater than 7 days, that you have a greater risk of persistent use. And that's sort of, I can see the correlation between, higher doses, longer infusions, sort of makes sense. And hospital length of stay, same thing. It varies between studies, but especially the time period after the patient gets discharged from the ICU to the floor or the step down, that time period seems to be more associated with persistent use. So that's a perfect moment to transition into transition of care. So it's not just the ICU stay that matters, it's the patient's whole journey from their ICU stay, or from admission really, till discharge. Transition points are high-risk moments for opioid continuation, as it's the handoffs, really, where prescription habits can shape these outcomes. We all know that transitions in general, handoffs in general, are weak spots, and information gets lost, orders are continued, sometimes, or discontinued, or, they don't always know why certain medications were started in the first place. So looking at prescribing practices for non-opioid medical ICU patients to fluor, a couple of studies on this show that patients that come into the ICU without any opioids, stay in the unit, are mechanically ventilated, started on opioids, 45 to 60% of them are still on opioids when they go to the floor or step down. And the opioid intensity or the dosing seems to play a part there as well. So the higher doses they were on, more likely they are to continue once they transition out of the unit. So if we zoom in on the time period of when they're now on the floor and they're about to be discharged to home, not only are they at higher risk of continuing their opioids to the floor, but they're also at much higher risk of getting prescriptions when they get discharged. And discharge prescribing has also been shown to be a strong predictor of continuation. So in fact, 30 to 57% of opioid-naive ICU patients leave the hospital with a new opioid prescription. And this is really the same population as we looked at here. It's the same opioid-naive patients. They went to the floor with this, and then they go home. This percentage carries their opioids out from the hospital or to a facility. So what about transition to enteral opioids? Is that helpful when we're trying to wean the analgesic sedation in the ICU? There's actually evidence that transitioning to enteral opioids in the ICU as a part of this weaning strategy can extend opioid exposure. So opioid-naive patients that were started on a scheduled enteral opioid for this particular reason, a third of them ended up being prescribed a scheduled opioid when they were discharged to home. And that group, this is a study by Cram and his colleagues, third of this population was described with opioids. And that group ended up using opioids for 20 days in total, compared to 9 days to the patients who did not get enteral opioids. That's pretty significant. So the message is, what we send the patients out the door with matters, and stewardship at transition within the hospital and at discharge may be one of our strongest tools to reduce iatrogenic long-term use. So what stewardship practices can we perform at discharge, and basically from the ICU and also at discharge to home? Well, first of all, review discharge prescriptions carefully. Evidence actually shows that we frequently overprescribe. Even in opioid-naive patients, patients get both higher doses and more amount than they should need based on calculated requirements. We can use a discharge opioid prescription guide. There's an example there on the left side of the slide to help guide discharge prescriptions. So we prescribe. Doesn't often fall into our hands. It's more from the floor to home. But it's just important to know. There are discharge opioid prescription guides out there that we can use. So this is my last slide. So what can we do? This slide sort of summarizes the risk factors I've mentioned and suggests some mitigation strategies. So I would say limit opioid exposure. The dose is important. The duration is important. So you want to try to maximize, if you can in the ICU, come off the opioids, so maximize opioid-free days. That is helpful. You can consider non-sedation. And then you want to taper thoughtfully. When you are tapering or weaning, you can use structured taper protocols. You can include the pharmacist in this protocol. I put the opioid-free days again up there because if this is possible, it is very helpful. Adjuncts in general should be used. You can transition to methadone. If you have someone that you expect that is going to stay on opioids for a while, or if it is opioid use, someone with opioid use disorder, transitioning to methadone or buprenorphine, as Dr. Quaid talked about, would be helpful. And then we should remember we have, at least at larger institutions, we have pain specialists, addiction specialists, and palliative care specialists that we can consult for those more complex cases. We need to be mindful of transition stewardship, review and minimize the prescriptions on discharge. We could use a handoff protocol or a checklist to do so. Again, pharmacy can be helpful there. And then you want to do proper discharge planning. Review them again carefully, use prescription guides if you have them. And then you don't want to forget to educate the patient and the caregivers about the risks. And finally, it is a team approach. You need the whole team to be working together across ICU and floor and all over the hospital. So engage the teams in safe handoffs. Thank you.
Thank you so much. They were excellent talks. So we have a little bit of time for questions. So if anyone has any questions at all, please come forward. Or happy hour, that works too.
Let me ask you, how many of you have easy access to buprenorphine in your institutions?
Great, good. Hopefully you're using it as well. I think it's an excellent drug that's underutilized, and over the past year and a half, we've been using it a lot at Maine Health, and it's been really beneficial for our patients. Yeah, great. Okay, happy hour. Oh, you have a question?
Can you talk a little bit about your adjunct strategy? Because what I think we need to do is have like a balanced approach, right? And that's something that I think is like a big part of how you do that. So beyond just buprenorphine and methadone, what's your approach?
Absolutely. That's great. I think I have a slide that shows it, and we kind of talk about it in a review article that we published just in terms of comprehensive management for opioid use disorder patients. So we have an order set that basically utilizes the medications that we're very familiar with, and I think it's important to just make sure that it's on people's radars and that we're using these medications in standing doses. We are at luxury of being able to use continuous dexmedetomidine infusions for patients when they're in the ICU because we have the monitoring that can support it. So that's really helpful, especially for patients that we are concerned of also having concomitant potential for withdrawal. Acetaminophen, ibuprofen patients that you can use it for. Ketamine is something that we use a lot as well. However, it becomes minimally effective after 4 to 5 days or so. So we try to use it intermittently, but pretty much we're limited, right? We're limited by the medication that we have access to. Of course, we have the new sodium channel blocker that's on the market coming up. Of course, we don't have it on our formulary, but that potentially, hopefully, can be something in the future. Thank you.
It seems to work.
Uh-huh.
But it needs to be studied more, and we need to know what the side effect profile is because it was really narrowly in like a very narrow trial, right?
Yeah.
Does seem to work pretty well.
What patients are you using it in, if I may ask?
It's a good question. The colorectal surgeons have put it in their ERAS protocol, and then they're going to do a retrospective trial on it, which because they don't want to do a prospective trial, and that'll be interesting to see. They seem to have like pretty good efficacy with their colorectal patients, which makes a lot of sense for.
So are they starting it as inpatients, or is it kind of like a discharge medication?
Starting it as inpatients, yeah.
Wow. That's great. That's good to know. Great. Thank you. Do you have a question?
Yeah, I guess a question for you.
Yeah.
So when you initiate buprenorphine, especially in patients that are intubated, when I'm on the pain service, I usually get consent from them, especially if we know the patient has a tendency of leaving AMA or not following up.
Yeah.
Do you normally get consent from the family or have a discussion with the family before you initiate buprenorphine in patients that you're worried about opioid withdrawal?
Right. Yeah, it's a great question. And it really kind of depends on the patient. One of the things that makes it a lot easier for us to determine whether we're going to utilize buprenorphine if it actually is something that's already on their tox screen or something like that. Or for patients that we have signal that they've used, fentanyl or heroin or something like that, we are more inclined to actually administer it in those patients without actually getting consent. If we don't have a tox screen that is supportive of potential misuse of illicit substances, then that's when we would engage in those discussions. But it's a very important point that you don't want to just start it on a patient. And it's hard sometimes for patients that don't want to be on it, right? We've had those situations where we've had to come off of the medication. I think the thing that ends up protecting us is the fact that buprenorphine also is a pain medication. It is used for acute pain even more commonly. And so it's not something that you have to be so concerned about in terms of the ramifications of it, the negative implications, because you can just say you're using it for pain. That's a good question. Yeah. Great. Any other questions? Okay. Thank you so much for your attention. This was great. Thank you.